used in ovarian cancer.
Thank you.
And our other GYN cancers. So the most important recent advances in ovarian cancer would be anti-angiogenic therapy. That's the therapy that stops the small blood vessels from growing. PARP inhibitors, which we've been discussing, both in treatment and in maintenance. And then, of course, the increased use of the neoadjuvant chemo, so chemo before surgery. These are some of the biggest changes of the last couple of years. And then future directions in ovarian cancer are screening and prevention. Really, we need screening and prevention. We need a vaccine. We need something to prevent or let us catch cancer before it springboards and turns to a stage 3 type of thing. We need new molecular targets. Maintenance therapies are coming on board, as you mentioned, with Lynparza and how that has a new indication in maintenance and recurrent setting. But bringing those into the first-line setting is going to be kind of the next step. And then, of course, we need more quality of life and complementary approaches to care and support. That is actually from a slide taken from Dr. Lena Chan. Actually, most of that slide is. Cervical cancer, just a few quick slides on cervical cancer. The phase 3 trial, published in 2014, New England Journal of Medicine, addition of bevacizumab to chemotherapy improved survival by 4 months from 13 to 17 months. This is the first time we've seen that. It doesn't sound like enough, but it's finally moving the needle a bit. And it gives us another tool to use for women with recurrent cervical cancer. These are the curves, and if you remember, I showed you those curves with the HR of 0.27. Here we're looking at an HR of 0.67 on the right, 0.71 on the left. That's what we're used to seeing, and this kind of highlights why we're so excited about the PARPs. But this is what we have right now in cervical cancer. Biological targets in cervical cancer include immune checkpoint blockade. So there was a trial that just resulted using another immune checkpoint inhibitor called CTLA, well, it's a CTLA-4 inhibitor called ipilimumab. And they had a 1-year disease-free survival of 74%. This is in advanced high-risk cancer that was treated with chemoradiation followed by ipilimumab. And then there are other immuno-oncology drugs that are coming down in the clinical trials. We're looking at vaccination with a protein that endometrial cancer, the virus that causes endometrial cancer secretes, called E7. And so this is actually quite exciting. We saw in heavily pretreated cervical cancer patients in a phase 2 trial, a median overall survival of 7.7 months. Sounds terrible, but it's way better than we've seen before. And this is moving into third phase and is also moving into combination drug approaches. So important advances in cervical cancer, the addition of bevacizumab to chemotherapy for the treatment of recurrence, and then the exploration of immune combinations in the treatment of recurrence. So I want to just quickly mention the work of our awesome CRCs, our clinical research coordinators. We have a portfolio of clinical trials here at UC San Francisco, and we're continuing to add to this, and we are collaborating with the other folks across UCSF that have trials also available for our patients with GYN malignancies. The Gynecological Oncology group has phase 2 and phase 3 trials. The phase 1 program is headed by Dr. Munster, who will be speaking soon. I don't see her in the audience yet. So basically the trials there will be basket trials, meaning multiple different tumor types. They'll say solid tumors, and then we'll be able to put patients that have like a cervical cancer that we may not have a trial for. And then the cancer immunotherapy program headed by Dr. Lawrence Fong is doing really amazing work with first-in-human things, CAR T therapies, if you might have heard those in the news. Those are coming through his group. Our Gynonc portfolio in our division includes these four chemotherapy trials. The last one directly answers the question about platinum resistance. GYN49 uses as a phase 2 trial that looks at a drug called AZD1775, which is a DNA damage response pathway drug, plus chemotherapy, and this is for women with platinum resistant disease and ovarian cancer. The others are phase 3 trials. GOG 3012 is the maintenance right up front, so right after finishing chemotherapy and surgery and chemotherapy, looking at a PARP inhibitor called niraparib. GY004 is that combination of olaparib and cediranib in the phase 3 space for platinum sensitive folks. And then Ariel 4 is a phase 3 PARP inhibitor, rucaparib, versus chemo with recurrent BRCA mutant patients. Endometrial and cervical cancer, we have kind of limited trials right now, but we're moving quickly to open more. In endometrial cancer, we have 286B, which is a combination of carbotaxol and metformin. Metformin acts in a kind of molecular way. It's an old diabetes drug, but we repurposed it. And then GOG 3009 is this immunotherapy trial with a vaccine and then after chemoradiation. Coming soon, we have a couple other trials. One is a combination of an immune inhibitor, the Avastin and Taxol and Carbo upfront for ovarian cancer. We're very excited about that, and that's actually headed by one of the people in our group who was volunteer faculty with us. She's actually heading that up in her job at Genentech. We have a Garnet study using anti-PD-1 for recurrent endometrial cancer. That's coming soon, and then this CC 174016, which is a immune drug along with the vaccine trial for cervical cancer. And then we have a couple who are just temporarily closed. At any rate, that's what I got for you today. Any questions for me? Please.
So I thought it was interesting that you said that the finding about the fallopian tubes. Could you speak a little bit more as to how that came about? Did they just discover that every cancer was in the fallopian tube, or was there more?
Yeah, that's a great question. So the question is, how did this come about? This fallopian tube is the source of the high-grade serous ovarian cancers. How do we find that? You know, the first work came from a lab at Harvard by Chris Crum, as far as I know, or in his lab. Where they took a bunch of women that had risk-reducing salpingophorectomy, so they'd had their ovaries and tubes removed because they had a high risk for getting ovarian cancer due to BRCA mutations in their families or in themselves. And they looked very carefully, and they found these spots that had overgrown the lining of the end of the fallopian tube. And then they started looking for p53 mutations in these overgrown spots, and they started finding p53 signatures. And if they've had cancer at the same time, they found the same cancer with the same mutation in the fallopian tube signature area as in the cancer. And so, and this was an unexpected finding, really fascinating. They could also see that additionally they get DNA damage in these same little built-up areas. And so this was the first idea that, hey, this is actually maybe coming from the fallopian tube. This, in addition to the fact that we've never found a precursor lesion for these diseases really in the ovary. Yes?
It plays off of the question that you just answered. Sorry for going before you, but does the p53 mutation, is it consistent with all serous cancers across the board, gynecologically, that mutation?
That's a great question. So with the high grade,
What's the high grade?
for both uterine and ovarian, high-grade tumors are associated with p53 mutations 95% of the time. The low-grade serous tumors are not.
Okay, what about BRCA? Is the p53 common in BRCA, or is it?
Yes, it is.
BRCA?
Yeah, it is quite common.
Okay.
Here in the front.
If you didn't get BRCA when you had peritoneal cancer, which was 3 years ago, does it mean if your cancer doesn't reoccur, then you won't get BRCA, or could BRCA just crop up anyway?
BRCA's a gene. I have it from the day you're born.
So I'll answer that two ways. One is that there's a genetic thing that gets passed on through families. That's the BRCA mutation that we've been talking about. However, some tumors develop BRCA mutations in the tumor. That's called somatic mutations, and that gives a higher sensitivity to the PARP inhibitor. But we can take some of that stuff into the small groups. We have 2 minutes, sorry.
2 questions.
Yeah, people in the back have been jumping, yes.
2 minutes. Uterine cancer with the genetic mutations that you presented. So in 2010, I just got genetic testing for just the BRCA and Lynch syndrome and tested negative. Is it common to get tested again for some of the newer, like the POL and the MSI? And if so, is there any benefits of that? Are there any maintenance drugs, or if there's a recurrence, is it better to know that ahead of time?
So the question is, if someone has had genetic testing, right, so of their genes, and didn't find a genetic predisposition, but but they have uterine cancer, or some of these other things that would be worth testing for. So those things that I talked about, the MSI high, and the I just blanked because I'm sleep deprived. And the POLE, thank you. These are mutations in the tumors, and it may be worthwhile in doing tumor sequencing when we are looking for options and we're saying, hey, we need a clinical trial option, we need something off trial, we've tried all the stuff that's standard. Certainly one of the things that we do is we get UCSF 500 testing and we can identify these things, certainly. And we can also ask specifically for MSI testing.
But that's better if there's a recurrence, or what if you don't have any evidence of disease right now?
If there's not a recurrence, I would probably hold off on those expensive tests because there wouldn't be anything to do with that information. That's the way I feel at this point. Last question, please. Yes?
Oh, this test for, a clinical trial for AZD1775 for platinum resistant, is that clinical trial open?
Yes, that is. So the clinical trial for ovarian cancer, platinum-resistant ovarian cancer, called it's the GYN49 using AZD1775. The question is if it's open, and yes, it is open.